We're excited to learn more about the future of MRD testing, why it matters, and what comes next. With that, I'll go ahead and introduce our speaker. Our speaker today is Dr. Neha Korde. She is a board-certified hematologist specializing in the treatment of multiple myeloma and other plasma cell neoplasms at Memorial Sloan Kettering Cancer Center. She has a particular research interest in early plasma cell disorders, including MGUS and smoldering myeloma, and understanding disease biology that may promote transition to frank symptomatic multiple myeloma in some individuals. Her research focuses on monitoring minimal residual disease and understanding tumor resistance to improve treatment strategies through these efforts. She aims to advance myeloma research and develop new approaches for tumor control and eradication. And with that, I will turn the time over to Dr. Korde.
Hi, my name is Dr. Korde. I'm just going to share my slides here. Okay, well, it's such a pleasure to be able to talk to you today on a topic that I think is really near and dear to my heart that I've been focusing my research efforts on for quite some time. The topic of today is really focusing on minimal residual disease testing in multiple myeloma. My name is Dr. Neha Korde. As introduced earlier, I practice in New Jersey and in New York at Memorial Sloan Kettering sites, and thanks for attending. Okay, so a little bit about some of the topics I'm planning on covering today, which are really going to focus on what is MRD testing, why is it important. I want to hopefully dive into some of the methodologies with a real focus and spotlight on peripheral blood testing, which I think is really up and coming and innovative. And how we can really adapt and utilize these MRD methodologies in the future, perhaps even guide some therapy decision making. And then hopefully at the end, we'll have some Q&A session. So really to start off, at a basic level, what is MRD? MRD is minimal residual disease testing, which really refers to the detection of remaining cancer cells of disease markers that represent cancer cells after treatment. MRD allows us to measure disease beyond traditional blood-based response criteria or serum markers. And the reason why we really need it these days is because our treatments are getting so good, which is actually a great thing. Our current treatments are reaching anywhere from 90% overall response rates for our newly diagnosed patients and up to 60 to 70% complete responses just using traditional serum-based response criteria. So what MRD is doing is allowing us to have the ability to detect the disease really beyond the surface. And really the reason why it's crucial is because it's some of the first steps that we have to take in order to understand what a potential cure looks like for our patients, or what we call a functional cure. Why is it important? At the most basic level, the deeper the response, the longer the remission. This is one of the older studies that is looking at MRD negativity. And what it's demonstrating is, this was from the Spanish group, where they looked at 3 pooled clinical trials, and they were using MRD technique, which is flow cytometry, which we'll get into in a little bit later. But this graph is essentially showing us is that MRD, actually, when it's applied, it can be one of the strongest predictors of overall survival. So this trial and others has really culminated over the last several years, where to the point where we've actually been able to aggregate a lot of the data in the form of meta-analyses with over 93 publications and over 8,000 patients, all telling us similar findings. Whether a patient is in newly diagnosed, transplant eligible or ineligible, or if they're relapse refractory, MRD negative disease status have longer remissions and overall better clinical survival outcomes compared to those patients that are MRD positive. And how this has really bared out is it culminated last year where the ODAC committee, which is an advisory group, recommended to the FDA to use MRD as an accelerated approval endpoint in multiple myeloma clinical trials. And so with this, using MRD as a surrogate, we can essentially start to really change the landscape of how we treat our patients, how quickly therapies are approved, which really equates to more access to life-saving drugs for our patients. So switching gears and talking a little bit about more on the methodology, I kind of wanted to discuss how we actually start to think about MRD testing and what are the methods behind it. The first rule that I wanted to go over is when we think about MRD, I want you to think about it in terms of components and compartments. First, looking at components. Components is referring to really what we're talking about is what are we actually measuring? We have three options: tumor cells, proteins, and tumor DNA from the cells that are derived. The second is compartments. Compartments is simply referring to where are we going to look? Are we looking in the bone marrow or are we looking in the blood? Now, importantly, cells and the DNA that they're derived from, they're usually found mostly in the bone marrow for myeloma patients and for myeloma. And that's really primarily for the reason that plasma cells, the normal myeloma cells, that's where they live. They like to stay in the bone marrow. As we've learned over the last couple of years, even in early disease neoplastic states like MGUS and smoldering, we're starting to realize that the cells and again, the DNA that they're derived from, we can actually start to pick them up in the blood. But in general, bone marrow is the place to look. The other thing to know is that as patients have increased relapsed and refractory disease states, the cells can have increased travel through the peripheral blood. So that might be another reason why we can start to pick it up in the blood. And then the third component to all of this is our technology is advancing at a really rapid rate, where to the point where it's actually able and capable of picking up disease in the blood, not just in the bone marrow. Finally, when we think about protein component, that traditionally we've always checked in the blood. And that primarily still remains the focus of that particular compartment, where we're really looking at the M-spike proteins and the antibody proteins that the myeloma cells are making. It still tends to be the best place to check is in the blood. And although I'm not going to go over it more in detail during today's talk, I do want to kind of quickly note that in myeloma, which can be a very patchy disease, we also like to focus on understanding where lesions can focally occur. And we use techniques like imaging, PET scans, MRIs to allow us to put in the context of compartments more into context and even evaluate extramedullary disease sites. So while it's not a component that I'm going to look at and discuss today, it is something worth mentioning because as we talk about MRD, it's important to understand how do we look at the whole body as a whole. So now that we know a little bit about components and compartments, the principles and the methods that we are applying to these areas are pretty similar. So I'm going to go and talk about the techniques a little bit more in detail one by one. But the first thing that I want you to kind of understand is that when we check for cells, for instance, we can actually look both in the bone marrow and the blood and use actually very similar techniques called, for instance, flow cytometry. There may be a little bit of variation using flow cytometry from institute to institute, and that might affect the sensitivity rates, but the principles are essentially the same. This also applies for DNA. So when we're looking at DNA, for instance, we can look both in the blood and the bone marrow. We use a technique called next-gen sequencing or next-generation sequencing. The DNA sequences that we check for might be a little bit different, but the concept is still the same. And then, as stated earlier, when we're talking about specific protein or myeloma protein, M spikes, we're really checking this still primarily in the blood, and I'll go into that a little bit deeper. So the second big rule that I want you to focus on when we think about the basics really has to do with sensitivity. Sensitivity of the test really, really matters. So when you're talking to your patient, to your doctors, you might hear them say things like, this MRD is 10 to the minus 5, or this MRD test only evaluates 10 to the minus 6, so on and so forth. What are they really talking about? So what they're referring to very simply is 10 to the minus 5 means finding one cancer cell in 100,000 cells, while 10 to the minus 6 means finding one cancer cell in 1 million cells. Obviously, when we look at this and we sort of think about it, being MRD negative as 10 to the minus 6 means you're in a deeper response compared to if you're only MRD negative at 10 to the minus 5. And that's what this graph from the IFM 2009 trial data is essentially showing, is that the deeper the response you are, essentially the predictable remissions are longer. So you can see that you can categorize, your MRD negative status. If you're an MRD negative by 10 to the minus 6, those patients have a deeper, longer remission compared to 10 to the minus 4 or 10 to the minus 5, for instance. The second big takeaway when we think about sensitivity is that just because a test or a method has the capability of reaching a limit of detection, for instance, 10 to the minus 6, it doesn't mean that the sample that is submitted to that test is always going to be good enough to actually analyze at that level. So there's a lot of other factors that kind of go into why a sample might be good or bad. And it's not just really based on the test itself, but really importantly, the quality of the sample, when that sample was drawn, and the timing of the bone marrow aspirate, for instance. At what point was that happening during a patient's disease course? All of these things matter. So for instance, the next generation sequencing testing that I'm going to discuss, that actually has the capability of reaching to 10 to the minus 6, but perhaps only 70 to 80% of the samples are really good at reading at that level. So again, it's not just about the test itself, but what about the sample that's submitted? Okay, so let's go over some of the basics. The first technique that I'd like to talk about is the flow cytometry technique, which I alluded to as one of my first slides. This was really pioneered by the Spanish group, as well as multiple other groups around the world. But it's a Spanish group that has really sort of integrated into evaluating it in clinical application, trial context, so on and so forth. What this technique is doing is evaluating either the bone marrow or the blood, but primarily a lot of the historical data has been through the bone marrow. It analyzes the surface proteins on the surface of the myeloma cells, and it can categorize and differentiate these cells from abnormal clonal plasma cells from normal plasma cells. The advantage of this technique is that you do not have to rely on a baseline sample with high tumor burden first. You can basically just do any time point that you want. You don't have to have a historical baseline identified. But the disadvantages of this technique is that the sensitivity can really vary from center to center. And there are only a few labs really in the world that are actually capable of reaching 10 to the minus 6, which is using flow cytometry. A quick tip is that when you're talking and listening to doctors talk about multi-parametric flow cytometry, we tend to use the nomenclature MFC, which stands for multi-parametric flow cytometry. That's usually talking about a sensitivity level of 10 to the minus 5. And when we use the terminology NGF, or next generation flow, that's usually referring to a sensitivity threshold of 10 to the minus 6. So it does, help just to kind of know a little bit about the nomenclature. The next test that we'll talk about is NGS, or also known as next generation sequencing. Essentially, what this test is doing is identifying a specific tumor DNA sequence, And the most common example that we use is the VDJ sequence, which really encodes for the B cell receptors found on the plasma cells. The disadvantage of this technique is that you always need to have a baseline ID sequence identified when the patient has high tumor burden. And in order to apply it, you'll need that baseline. In order to apply it in the MRD context, you always need the baseline sequence first. But what we're doing here is essentially looking for this clonal tumor DNA sequence. Like I said, VDJ is the most common one, but in theory, this test can broadly be applied using other unique somatic mutations or other unique DNA sequences to the particular tumor cells. Really, really important. The other advantage is that currently in the US, the adaptive assay or the clonoSEQ test using an NGS technique is really the only commercially FDA approved assay approved for testing MRD right now. A lot of other tests that I'm going to talk about later today might have a commercial lab that's able to do it, but the actual FDA approval for looking at MRD is really only the adaptive test currently. This test has the capability of reaching a sensitivity of 10 to the minus 6, but as we discussed earlier, important to know that doesn't mean that every sample submitted to this test is going to be able to really reach that threshold. Okay, so when you compare flow cytometry to NGS, how do they compare head to head? Essentially, what this is showing is that we have pretty good agreement when we're looking even at 10 to the minus 5 and 10 to the minus 6 level, it's around 85%. But importantly, what we're seeing is that the NGS assay consistently will find more disease compared to the flow cytometry. Now, for this reason, we think that NGS just in general tends to be slightly superior compared to flow cytometry testing. And when people have looked at this sort of bears out. This is, again, another reference to the IFM 2009 data where they looked at NGS MRD technique in patients that were already known to be flow negative. And what they found was that actually NGS was capable of discriminating between a PFS outcome in patients that were NGS positive versus patients that were NGS negative. Again, this is looking in the bone marrow. What's one thing that's important to know is that the flow cytometry test that they applied to this particular data set was 10 to the minus 4. We're really not sure if this would necessarily hold true if we looked at, for instance, flow cytometry 10 to the minus 5 or 10 to the minus 6. And in fact, another clinical trial called Forte, which was looking at a different therapy backbone, they actually looked at a higher flow cytometry sensitivity, and they could not reproduce these findings. So, we have to sort of take this with a grain of salt, but important to know. Now, let's move on to the protein assays, which, again, currently none of them are FDA approved for evaluating MRD. Doesn't mean we can't run the test, just means that they're not validated to that stringent level. So importantly, starting at the most basic level, we have what we call our serum immunofixation, electrophoresis, or our SPEPs, our serum protein electrophoresis. This is our most basic assay evaluating the presence or absence of a monoclonal protein in the blood or the serum. It's capable of detecting 12 milligrams per deciliter or higher in terms of M-spike protein. And as you know, we've been using this particular test for a long time. Now, moving on, we have two particular categories of what we call mass spectrometry protein assays. The first one is called the MALDI-TOF assay. The specific type of MALDI-TOF assays that are available include MassFix and Accent. These are commercial labs that you can use and send your samples to. These assays, essentially, what are they doing? They're evaluating the time of flight the proteins are in a particular sample based on their mass charge ratio of the M protein. The technique is able to characterize the protein profile and sort of look at the band, look at how much protein is there. This technique, although the lab it's commercially available, some centers have switched completely to aborting all IFEs and completely doing MALDI on patient samples. It allows the lab to run through samples at a high volume, and so it's very efficient. What we also see is that they're 2 to 10-fold more sensitive compared to the IFE, so more efficient, more sensitive at picking up protein, but they also have their limitations in terms of MRD. So one of the things that we'll talk about and look at the MALDI-TOF data is how it particularly compares to some of the bone marrow samples, for instance. But in general, although MALDI is better at looking at protein levels compared to IFE, it's not as quite as sensitive as the last mass spec technique that I'm going to talk about, which is called the clonotypic liquid chromatography mass spec, or LC-MS, or LC mass spectrometry. What is this technique? What this technique is doing is, again, it's looking at mass spec. So we're talking about the actual protein mass and applying what we call a pre-enzymatic digestion step, where essentially the serum proteins are being digested into little clonotypic peptides. And then this is run through the mass spec machine. And essentially what we're able to do, or what the labs are able to do, is have an output of a higher sensitivity using mass spec, because the samples are pre-enzymatically digested, breaking up the protein molecules into smaller little peptides. By doing this, you're able to yield out a higher sensitivity compared to the MALDI-TOF. The potential for this LC-MS test, or clonotypic LC-MS test, is actually a lot greater than MALDI. Our capability of reaching a sensitivity threshold is higher, 1,000 timefold compared to 1,000 times compared to IFE. However, the disadvantage of the LC mass spec is that you do need a baseline sample. So going to go into MALDI a little bit more, and then talk a little bit more about the LC-MS techniques. So when we compare peripheral blood MALDI-TOF, for instance, to bone marrow using NGS and flow cytometry techniques, we see that the agreement is around 67 to 70%. This slide is derived from a study called the Atlas study, where they were looking at KRD maintenance versus Rev maintenance. Just to quickly orient you to the graph here, what you're seeing on the right is, in the green, is the agreement between the two tests. The top panel is comparing MALDI to NGS in the bone marrow. The bottom B panel is looking at MALDI compared to flow cytometry in the bone marrow. All the green is what we're seeing is in agreement, where MALDI is agreeing with the bone marrow, either through NGS or through flow cytometry. The red is where we're disagreeing. And essentially what we're seeing is that when you compare MALDI to bone marrow, NGS, and flow, the agreement rates are actually sort of similar, around 67 to 70%. Not bad. Again, one of the things that's interesting out of this particular study that came out was that the degree of agreement actually improves as patients are further out from induction therapy and from transplant. And One of the reasons why that might be is because when we're thinking about myeloma proteins in particular in the induction and post-transplant setting, the myeloma proteins can oftentimes be recirculating in the body. So meaning that the cells are not necessarily generating new particular proteins. It takes a while for the body to clear out some of these myeloma proteins. So earlier on, when you're comparing MALDI to these bone marrow techniques, the cells themselves might be gone, but MALDI is still picking up protein that is essentially sort of still circulating about the body. And it might not necessarily be the best degree marker for what the disease is really truly doing at that time point. The second thing to really know about this test is that this study actually used samples, MALDI samples that did not have any baseline samples. So it's not like a baseline MALDI serum sample needed to be done in the beginning when patients had not had any treatment or high burden of disease. You could essentially just do a MALDI test, TOF test, without requiring a baseline sample. So that was sort of important to highlight. How does MALDI compare in the blood when you compare it to NGS in the bone marrow? And this again is looking at the same study, the Atlas study. So starting from left to right, we see what this graph is essentially showing is that at least based on this data, when you look at patients that are bone marrow NGS negative, which again is the panel on the left, MALDI does not seem to add too much to distinguishing clinical outcomes. So head to head, MALDI is not necessarily picking up more differentiating clinical outcomes in patients that are bone marrow negative. When you combine the MALDI test with bone marrow NGS, however, that's this middle panel, we actually see that patients that are double negative, so essentially negative in both the blood and the bone marrow, have improved outcomes compared to those patients that were only positive or positive by one technique or negative by one technique, however you want to look at it. That's what this middle graph is showing. And then the third panel is essentially driving home the point that despite us looking in the blood using MALDI or even bone marrow 10 to the minus 5, the thing that we see that really translates to some of the best clinical outcomes in the long term in terms of MRD negativity is being sustained at 10 to the minus 6. So what does all of this mean? Essentially, right now, bone marrow MRD assessments are still really needed. Now, how about when you incorporate a third technique, looking at flow cytometry or next-gen flow in the blood? Does this make a difference when you add it to the MALDI bone marrow mix? Again, what this is showing, this is data coming out from the Spanish group. When you look at this and you put all of this into context, what we're seeing is peripheral blood flow cytometry, sort of similar to the MALDI picture. When you have double negatives, those patients have superior outcomes compared to if you only had one negative test and the other test being positive versus those patients who had both positive tests. And this is the same story if you look at peripheral blood flow cytometry and you compare it head to head with MALDI, or if you look at peripheral blood flow cytometry and if you compare it to bone marrow NGF. So how about that other test that I mentioned earlier, which is the liquid chromatography MS, the clonotypic peptide assay? So this was conducted in, again, that IFM 2009 data set, which they looked at this LCMS assay. And they're particularly focusing their efforts during patients that were on the maintenance period. So just to quickly orient you, the orange line is looking at serum immunofixation. That's all at 0. The plus signs or the green X sign down at the bottom of the graph is looking at the bone marrow assessments. Plus refers to MRD positive. The green X is looking at MRD negative. And then that blue line that you're seeing is really looking at the LC-MS kinetics or the protein assay, looking at the clonotypic peptide assay. And the yellow highlighted area is patients that are during maintenance. And really what we're seeing is that when you look just by serum immunofixation, everybody in these scenarios is at an IFE at 0. The bone marrow is picking up either positive or negative disease, but this peripheral assay, the LC-MS assay or the clonotypic assay, is allowing us to track what the myeloma protein is doing below the IFE sensitivity, but above the bone marrow sensitivity. And so we're able to track the kinetics of the disease a lot more efficiently than, for instance, a bone marrow time point, which is only one single time point once a year. So what this is highlighting is that we may be able to track the kinetics of the protein during patients that are in maintenance and see, how that relates to the bone marrow overall. So what does this mean in general? How can we start to combine some of what I just explained? On one sense, I'm telling you bone marrow is still supreme. But does that mean that we're forever going to be stuck with bone marrows? And how this may kind of, how we can start to combine and think about all of these different techniques is looking at a framework where we can imagine where we're combining the techniques. So for instance, in an example, if I have a patient that's MRD status and I'm checking their peripheral blood using, for instance, a MALDI technique or, another mass spec technique like the clonotypic peptide assay, I could be checking that patient's assay a lot more frequently because it's the blood. However, if the patient turns positive in the peripheral blood, that might prompt me to go ahead and check a bone marrow just to see how deep the residual disease is in the marrow. If the bone marrow is negative, but the blood is positive, I could consider just continuing to monitor. If the bone marrow is positive and the blood is positive, then you can consider thinking about potentially still monitoring, although we don't 100% know what that means. Based on what I just showed you, those patients might be more at risk for relapse. Or you could consider doing even a treatment change. Or maybe none of this really matters. It's hard to really say. But I think the thing that I want to sort of point out is that even though right now our standard is MRD monitoring using bone marrow, we can conceive of a future where we're integrating peripheral blood assays into the mix. So we're saving patients from bone marrow assessments. And this might be helpful in the future. Okay, so rule number 3, now what? So you might say, all right, great, Dr. Korde, not all the tests are available. I want to check to see if I can get an MRD test, or maybe that doesn't matter. My bottom line thing that I would say to you is always ask your provider what's available, what's validated. Currently, like I said, the clonoSEQ NGS test of the bone marrow is the only thing that's FDA approved in the US and has much more validation. We at institutional academic centers often will use flow cytometry. We'll have good data to back that up, but that doesn't necessarily mean that every center has that capability. Knowing the sensitivities matter. And then the last part of now what means, all right, just because the test is available, my doctor runs the assay, I get some result, either I'm MRD negative or I'm MRD positive. Do we really know what to do with this information? And that's what my next section of my talk is going to be, is focusing on how we can start to think about using some of this in clinical context. Important little hint, MRD is not the only thing that's going to matter. Okay, so as a segue, how do we combine all of what I just talked about and look at it in terms of clinical practice and moving science forward and integrating it into patient care? Okay, the first place that I want to start out is the easiest, which ODAC sort of helped us out in 2024, is using MRD as a key eligibility criteria and as a primary endpoint. This trial is the ORIGUS trial, recently published last year, but also presented at IMS. This is a phase 3 study where patients were enrolled during their maintenance period. They were randomized either to Revlimid or Revlimid plus Dara. And the biggest thing that I want to point out is that the primary endpoint of this trial is MRD negativity at 12 months. So here's an example where we're using MRD for clinical trial endpoints. And what they were able to demonstrate was that patients that received Dara-Rev had a higher level of MRD conversion at the 1 year mark compared to those patients that were only on Rev alone. And what's really interesting on the graph on the right is that even if you were MRD negative by Rev alone, or if you were MRD negative by Dara-Rev, you're seeing that your remission status outcomes or your PFS outcomes are very similar and comparable. So it almost is, again, the old adage of it doesn't matter how you get there. If you get there, that's kind of what matters. But if you use this doublet, it's more likely to push you into response. Importantly to know is that what will be really interesting as this trial sort of reads out further along is how well do you sustain that MRD negative response. The next example of where we can use MRD, the classic example, which is the MASTER study, it was presented several years ago by Luciana Costa and colleagues. This is an example where investigators were using MRD to de-escalate therapy. So with this study, they enrolled patients, and essentially what they did was they treated patients in blocks of quadruplet chemotherapy. The backbone that they used was Dara-KRD in the study. If patients achieved 2 consecutive MRD time points, they essentially entered what they called this MRD negative shore state, and patients stopped all therapy. So yes, you heard me correct. They actually took patients off of treatment, which is something that, these days, we in the era of maintenance is not necessarily common, but this is how much impact the MRD negativity, can tell you about a person's disease. And so what they found was essentially is that patients did okay after stopping therapy. If you were standard risk, you had less likely of a risk of progressing. Important caveat, however, is that if you had 2 or plus high risk mutations, then you were 4 times as more likely to progress. This was regardless of if you achieved an MRD, even in patients that achieved an MRD negative status. So what's the important lesson in all of this is that MRD status is not necessarily the only thing that matters. Aggressive disease biology, high risk categorization also makes a difference in terms of understanding how to think about the disease. And what about sustained MRD? So I alluded to this earlier. This is trial data from my own center at MSK. We took patients that were MRD negative sustained for 3 years, and they were on maintenance therapy, and we stopped their maintenance therapy and looked at outcomes. A similar study was published and looked at by the University of Chicago group. The study is called MRD2 Stop. And they used 2 years of MRD negativity. But essentially what we're showing in our trial, and it's pretty similar to what the Chicago group has seen, is that once you stop therapy, most patients clinically still remain in a clinical remission. Approximately around 28 patients or 28% of patients converted from being originally MRD negative to MRD positive. Majority of those patients remained clinically stable without actually meeting clinical criteria. When you looked at clinical progression, the remission rate at 24 months was around 89%. So most of our patients still remained clinically stable, even if they converted over to MRD positivity. Okay. What we are eventually going and headed towards are more trials looking at MRD, using it as a clinical trial endpoint. I want to point out the SWOG 1803 dramatic trial. This trial is essentially looking at over 1,000 patients. Patients are randomized to either receiving Rev-Dara versus Rev alone. They will have an MRD assessment after 2 years of therapy. If they're MRD negative, then they'll get re-randomized to continuing therapy or stopping their maintenance therapy, and then they'll look at clinical outcomes. Those patients that are MRD positive after 2 years of being on maintenance, they'll just continue their treatment. And this is probably going to be one of the largest to date trials that's looking at whether or not patients that are MRD negative could potentially stop therapy and discontinue their therapy. So all in all, is MRD negativity the only thing that matters? I think I might be biased based on some of what I've showed you, but I want to say no, that's not the case. Actually, it's not just MRD factors that matter. Increased yes, we're interested in looking at sustained MRD negativity, even though we know that those patients, have improved overall survival outcomes, remissions. There might be an opportunity to get treatment-free periods for our patients, might accelerate drug approval processes. But some of the things that we are also looking at that don't involve MRD at all actually have to do with quality of life. How tolerable are these treatments for patients to kind of continue? If a therapy is really good at giving you an MRD negative status, but it might give you a poor quality of life outcome, is that really the best option for patients? Many of us will say, no, not necessarily. So you have to think about it not just only as MRD is the only thing that matters. That's not the case. And as we learned from the master trial, high-risk disease biology also matters. And then the other thing that I wanted to mention is we've had a lot of data looking at how great MRD negativity is, but we're also noticing that there are a group of patients that are low positive, MRD positive in these persistent, sustained disease categories that are also deriving clinical benefit. So I think there's more that we still really need to learn and understand. So where does this all potentially go? If we look at it in terms of how we can apply it, MRD testing gives us the promise of potentially reading out trials earlier, guiding bone marrow assessments. We can, use blood-based assays in combination with bone marrow assays to evaluate MRD. It can hopefully guide escalation or de-escalation, and then finally, hopefully it can start to help define what a potential cure or a functional cure looks like. As I leave you with, some of the main points, just to kind of quickly wrap up, MRD allows for disease assessment beyond standard measurements that we know. We also know that deeper and sustained responses improve the clinical outcomes like remission status and survival status. As we talked a little bit about the method considerations, we think about evaluating MRD in components and compartments. The sensitivity of the test matters. Not all tests are available or validated, so talk to your doctor. But again, currently the FDA approved in the US is really clonoSEQ at this point. We're still trying to sort out how all of this applies to clinical decision making. And in that context, MRD is not the only factor to consider. We have to consider other things like toxicity, high risk disease, and even the idea that persistent MRD positivity, actually, there is some benefit to continuing therapy or not continuing therapy because not all patients clinically progress, even if you're MRD positive. And then really understanding how we can apply some of this testing in the future. Thank you so much for your attention.
Thank you so much, Dr. Korde. I know I learned a lot. I really appreciated your tables and everything, just kind of laying out the different methods for MRD testing and breaking down what it looks at and what those results actually mean. So I think that is a good takeaway for everybody who was able to join today. So thank you. Now is the time for our Q&A. So those that have questions, go ahead and put those in the Q&A box. We've already got quite a few, so we'll get through as many as we can. Any that are left over that we're not able to get to, I'll do my best to find some resources so that we can get those in the follow-up email. So the first question has to do with like targeted biopsies for bone marrow. There's always a question, if you got a sample from one area, you had 60% plasma cells, and then a couple weeks later you had another sample, 30%. What does that mean? Would targeting be necessary, or what are your takes on that?
Yeah, I sort of skirted around this issue a little bit, but I alluded to it. That's probably where this big gap of imaging really provides us context on what needs to be a targeted biopsy versus what doesn't necessarily. So, for the most part, we think of bone marrow as a liquid-free reigning state where, you biopsy one area and there's not a lot of differences. For instance, if you go in the other hip. But we know that myeloma can be a very focal, spotty, patchy disease. And where the imaging comes into play is allowing us to take a step back and saying, hey, do we have evidence of focal lesions? And is that where we really want to put our biopsy needle? And what I tell patients is it really just depends on the clinical situation. If your blood assays are coming back negative, and, your bone marrow is negative, that last layer of getting a scan that is negative means that I'm really not missing something. And, what we all know as being in the field is that for every rule, there's an exception. I've had, every rule you have a case where you think, oh, it's a very systemic disease. But then we also have patients that are primarily all focused multifocal plasmacytomas. And so that's really where that imaging portion, which I didn't go over, but it's its own whole separate topic. But that's where that would help.
Okay, awesome. Thank you so much. We had a question from early on in the presentation. There was a slide that said LOD. Can you tell us what LOD stands for?
Yes, sorry about that. LOD is essentially limit of detection. So it's a standalone as you just sort of look at the way I like to sort of think about it is looking at sensitivity for just the test itself. And then sensitivity is really referring to sort of the changes that you can see within a test itself, going from like, for instance, sample to sample, or the variability within, the quality of a sample. So it's very similar to what I would refer to as sensitivity.
Right. There's a question about what the highest sensitivity achievable with flow cytometry is.
Yeah. So right now, I think I also kind of alluded to this. There are there are centers that are able to reach it to 10 to the -6, as far as I'm aware of. But this is not something that is very easily accessible. Some of the greatest flow labs in the world are really, again, from the Spanish group, and they're able to attain a 10 to the minus 6 level with their NGF. I think I had talked a little bit about nomenclature and how we sort of think of what are we saying when we say MFC versus NGF. NGF is really referring to looking at flow at 10 to the minus 6, and that has the capability of getting to 10 to the minus 6. But again, it's not widely accessible. It really depends on the lab and the institution.
Perfect. Next question has to do with stopping or discontinuing therapies based on the MRD testing. When, or is this in the works, would we expect to see more practitioners looking at the possibility of stopping therapy based on MRD negativity?
Great question. And this is a great question because I think in the field, this is something that we're very interested in trying to be able to answer our patients because it's a very real world relevant clinical question. And I think a readout from, for instance, SWOG 1803, that dramatic trial would really help guide us because it's a large phase 3 study. And that second randomization is essentially asking that question. If you're MRD negative, what are the chances of, what are the clinical outcome endpoints that we're looking at for patients that are going to be in a sustained clinical response versus those that are not if you discontinue therapy. So that's what that I would say trial wise, while even we're conducting a smaller phase 2 study, that particular trial is something that I think we're all looking at in the future with excitement.
Perfect. Thank you. Love looking to the future and seeing what is possible. Getting off therapies and different things like that is really important to patients. So thank you. Next one just asked if the blood-based blood-based testing is not available yet, it's not FDA approved, will health insurance refuse to pay for that testing? Is that an out-of-pocket type thing?
That is the question. It's commercially available. I know that it is commercially available. You can send out your sample to it. But whether or not it is, for instance, FCA approved and insurance pays for it, I think that depends on the insurance, I would imagine. And those are the hard questions I think the doctors are trying to sort of navigate. But and as we build up more literature and validation around the testing, that will ease up the process. But it might end up being something where you're responsible for the cost of it.
Absolutely. There's another question just talking about baseline samples. Can you just review one more time which tests require baseline samples?
Yeah, this is such a fundamental, practical question and thing that we really need to talk about when it comes to MRD. So very simply, the things that need baseline testing is going to be your NGS assays, because you need that at a high disease burden to really evaluate what the tumor sequence is and what that clonal sequence is exactly. And the adaptive test, for instance, which is clonoSEQ, that test is requiring that you have a baseline ID sample, and any subsequent MRD time point hinges on the fact that they know exactly what that ID clonal tumor sequence looks like. So that's one example. And then, although not yet validated or FDA validated, that clonotypic LC-MS test that I referred to, those, I believe, those need a baseline sample as well, because they're looking at particular peptide sequences and analysis as the M proteins are sort of pre-digested. So you need a pre and a post sample. And these are the things that actually increase the sensitivity. So it's almost like if you know what it is that you've identified you're looking for in the baseline, then you can go ahead and almost fish it out during an MRD time point.
I love it. So I'm guessing as those develop, looking towards the future, during the diagnosis phase, we may see more blood being sent to look at those different proteins so that the blood-based test could be used in the future.
Correct. And on that note, I think some of the commercial labs that are doing like the LC-MS, they're actually helping access patients to get like at least a stored sample. So you have one in the bank. So, there's programs like that out there where they're sort of looking to see you can store a sample. And then for future use during MRD analysis, it will be helpful because you could just take it out of the freezer.
Perfect. All right, and we've got several more questions, but we're kind of getting to the end of the time with you, Dr. Korde. So I think I will put the rest of these questions in my bank and either get to them with some answers through the follow-up email or use some of these for future webinars. So I want to thank you again, Dr. Korde, for your time that you spent with us today. It was really enlightening and really helpful to help understand where we've been with MRD testing and where we're going. So thank you so much.
Thank you so much.
All right, I'll go ahead and we'll move on. Oh, oops, wrong direction. All right, if you have any questions about bispecific antibodies, I want to encourage you to check out our new bispecific antibody guide. This simplifies the science behind bispecific antibodies and will give you an in-depth look at what they are and how they may be part of your treatment journey. As you leave the session today, we'd like you to take that time to fill out the 2 to 3 minute survey so that you can tell us what we can do better, how we can improve, and what topics are important to you so that we can make sure that those topics are available in our upcoming webinars. Here's just a few of our upcoming events. On Tuesday the 4th, our bi-monthly blood cancer financial Q&A will be happening. You can register now and submit those questions ahead of time or ask those questions live during the event. On February 7th, we will be talking about how BRCA and other gene changes influence multiple myeloma risk, treatment, and your family's health. So important information there. And then on February 11th, we have a topic of new options for transplant in eligible or deferred multiple myeloma patients with some recent trial insights. We have many more virtual and in-person events in the works, so stay tuned. The link to sign up for any of these events and many others is found at the bottom of the slide and will be sent out in our follow-up email. I'd like to again thank our sponsors, Pfizer, Regeneron, Johnson & Johnson, Sanofi, Adaptive, and Genentech. Before we go, I wanted to highlight the Track My Disease feature in HealthTree Cure Hub. Once you've connected your medical records, the Track My Disease feature provides you with the ability to gain one-of-a-kind access to your health information encompassing lab results, genetic profiles, and treatment histories, offering you invaluable insights into your own medical journey. On the screen, I have the link to sign up for HealthTree Cure Hub, along with the email address for our amazing patient navigators who are available to address any concerns you have or to help you with those connections. I'll also include this information in our follow-up email. And finally, I just wanted to say thank you once again for helping to build a strong multiple myeloma community. I've added my email address to this slide, and I really do encourage you to reach out if you have any questions or if there's anything that I can help you with. Please send me an email. I love hearing from you. And I appreciate all of you and hope you have a great rest of your day and hope to see you at another webinar again soon.